So thank you, Christian, and I'm just very honored to be here amongst all of you today. The Peggy Lillis Foundation I've known since I met Christian probably about a decade ago, and we were working hard on getting hospital-acquired and healthcare-associated infections reported nationally. So a lot of the work and the numbers that you see up here are because of the work of advocates before you, really taking something that people thought wasn't going to be possible and making it happen. And so really the purpose of today's panel is to talk, to bring it to a more grassroots level. You've heard a lot about national efforts to work on issues either directly related to CDI or similar lessons learned. And so today we're just really going to take it down closer to what can you do in your own community, specifically on the state level. And so Christian's put together a great panel. We're going to start with just talking about really what is the role of states in healthcare, how do state laws and regulations affect how healthcare is delivered in your own state, and it can vary tremendously, as you'll hear. And then we thought it would be really important, as many of you know personally, the impact of a healthcare error or misdiagnosis can have on a family. And so we've invited Tony Galbo, and he's going to share his story and the work that he's been doing to honor his daughter Gabby's life. And that story is around the issue of sepsis. But as you're thinking about CDI and your work in CDI, think about the lessons learned there, because Tony has been a great supporter of the Peggy Lillis Foundation, and I think he has a lot to share with us as an individual who's taken great loss and brought it to a positive end. And then we're going to be hearing from Tammy from Merck. And she'll be talking, bringing us back out of the sepsis arena and maybe bringing it a little closer to the Peggy Lillis Foundation's mission and the work that we're doing with the Peggy Lillis Foundation. And then hopefully that will be about 30 to 35 minutes, and then we'll open it up to questions and hear the issues that you would like to discuss. And I, having been involved for 15 years at the state level in advocacy around patient safety and infection prevention, will try to bring in some of the lessons learned that we had over the years that we were working on infection reporting, taking it from only 2 states to 30-plus states doing statewide reporting. So hopefully it'll be informative, and we'll get right to it. So I'll just hand it off to Janet.
Okay, great. Thank you. So we've alluded to this some already. And again, I'm Janet Hamilton with CSTE, and I wanted to switch gears now to talk more about the state level. So my current job is representing all epidemiologists that are working in applied public health epidemiology with CSTE. But prior to joining CSTE, I worked for the Florida Department of Health, and I was there for 15 years. And one of my roles and responsibilities was overseeing some of our state rules and regulations about disease reporting. So there is a lot of value and power around state laws and regulations and how they individually support surveillance efforts. So if you could go back. Thanks. Typically, it's the state laws, actually, that govern disease reporting activities and that enable collection of personally identifiable information. It's the states, not the federal legislation, that supports this. Now, I will say, NHSN is a very specific tool designed around healthcare-associated infections, and because it has been associated with CMS and CMS reimbursement dollars, that does provide some very specific power around the collection of identifiable data as it pertains to a healthcare-associated infection. I want to also point out, just as Dr. McDonald was talking, that disease problems are not just healthcare problems. They're not just facility problems. There is issues around community-acquired disease, and state laws and regulations, whether it's for healthcare-associated infections or not, really supports that broad spectrum of activities. State laws also can require processes for how things should be reported. So, for example, when we talked about nationally notifiable conditions and making something nationally notifiable, there is a recommendation that can come with that position statement about what states should do, but because of the way that our country is set up, it's actually the state law that could govern, is this reported via an electronic mechanism, and what that mechanism should or shouldn't be. And so it's that network between federal recommendations and actual state laws that I think becomes really critical. I would say states work very hard to defend patient security and take the responsibility of collecting that identifiable information very seriously. Typically, when states pass information on to the federal level, this is most nationally notifiable conditions, the information that's passed on to the federal level is de-identified. Again, NHSN does function in a little different way than this. The state law also specifically dictates who should report. And there are typically 3 key reporters, and those are hospitals, physicians, and laboratories. And the reason why it's structured that way is because it's associated with state licensing. So your law can dictate for those groups that are licensed within your state, and licensing occurs at the state level, who reports and how they should report. I also just want to kind of harken back to concerns that we hear raised on the side of public health around privacy. And I think, as I mentioned before, states take handling confidential data very seriously. But I also really want to let people know that states need it in order to do the work effectively. People see multiple practitioners, as we've talked about already. Our care and system of care is somewhat fragmented. People have lots of doctors. They get diagnosed multiple times. They go many different places and can have multiple laboratory results. There are reoccurring infections versus someone who's maybe treated and the infection comes back versus a totally new instance where they're acquiring the infection in a new way. And so I'm just trying to point out some of the pieces as to why your identifiable information is important, because obviously for someone who's maybe been within the system of care 7 different times, and with CDI that information is recorded 7 different ways, potentially, we want to be sure that we're still only counting an individual once or counting their reinfection correctly. So this is an example of states' list of reportable diseases. Each state is different, and those can be based on the fact that there are sometimes regional issues that are important to that individual state, but maybe something is not necessarily important at more broadly at the national level. A very specific example from Florida was for many years, we had Vibrio infections reportable, and those are because we have oyster collection that occurs in the Gulf waters, and we wanted to ensure that we were monitoring and tracking that effectively. That was not necessarily an issue that was of concern more broadly, but of course as our food structure has changed and with the way that it moves now, that is something that has now become nationally notifiable. The other thing that's true is one reason why there's variation is there's a lot of variation in resource at the state level. And so some states just don't have the resources to do certain kinds of things that other states potentially can. So in terms of how these lists get generated, I'm very familiar with the Florida process because I was doing that for 15 years. But what I will say is, even while I was there, the process changed, and it's different across different states. When I started, the process was very health department driven and very data driven, and then we moved into a period of what I would say was deregulation, and the health department is part of the executive structure, and making modifications to add regulations or add new things to be reported became increasingly difficult and time-consuming. So I also personally experienced situations where there were special interests connected with individuals who were able to work with individual representatives or individuals who were influential in leadership positions. And those mandates were sometimes made without ever involving public health or the practicing epidemiologist. And those were often fraught with problems and inefficiencies, collection of the wrong data to answer the wrong kinds of questions, because while people's intentions many times were good, I think we've all been alluding to some of the complexities. And so I think what I wanted to really underscore is that as you all are thinking of ways to be influential, that and you may be meeting with various representatives, that you also encourage people and those individuals to request to regularly meet with public health. Depending on how an individual state is structured, the request has to come to public health. Public health cannot actually go to the individual. And so that really underscoring the importance of this is important, and we want to ensure that you're working with public health. Please request that public health come to the table and work with you as we are working together on trying to come up with the best and realistic ways for us to do this. The other thing that's true about state reportable diseases and conditions, just like with nationally notification, you can add as many things as you want to this list, and it does not come with resources, which really leads me to my next topic, which is about funding and what does it really look like. While states have the lists of reportable diseases and conditions and they're authorized to collect that identifiable information, states get very little state funding to do things that they actually require by law. On average, I would say states get between 65 and 85% of all of their disease surveillance work is federally funded. So if you remember one thing from today, it's that states get their money from CDC to do surveillance. So when CDC's budget goes up, more money flows to the states. When CDC's budget goes down, less money comes to states to do the work. So even though the law mandates things at the state level, the resources are coming from the federal government to do this work. For me in Florida, in a state of 20 million people with over 150 reportable diseases, there were 2 individuals that were state funded to do disease surveillance work for general communicable diseases. There was no funding that came from the state government that supported the actual systems themselves. So, robust CDC budget is critical. I now want to touch on sort of data moving around, and there are different ways in which the data moves. We currently have a pretty fragmented healthcare structure, and in many instances, even though the data is likely stored electronically in an EHR in today's world, the data is stuck in long lines, and the data are moving more slowly than the disease. So I'm just putting this up here as a real-life example of a disease or condition report. And I will challenge you to read it and understand it. This is not a reflection of me photocopying it 100 times to make it look worse. So this is a lead laboratory result that was reported to the Florida Department of Health this past year. And so this is still what the process looks like in many instances. We are not where we need to be from a public health perspective. And so what does this lead to? Well, it's illegible, so it leads to errors. We're not sure who the patient is many times. Now, I did block out the patient information here and had the health department send it that way, but you can imagine what it looks like, and that maybe we're going to misspell a patient's name when we're transcribing it. The results are over on the far side, and maybe we're not actually even sure what those blood lead levels are, or the practitioner who reported it, in order for us to take time to call the practitioner back to say, we can't read this, can we please go through this information? So sluggish manual processes, paper records, faxes, phone calls, spreadsheets are still in widespread use across the public health infrastructure, and they have important downstream consequences, which is delayed detection and response to public health threats of all types, acute, chronic, and emerging. So yesterday's data systems must evolve and meet future challenges, and we have new opportunities, and I made this comment, but we're not reading paper maps anymore when we're making decisions. We have apps on our phone. They give us information about travel times, traffic, predictive analytics, and we can do this for diseases too. And we need to do this for diseases. My great-grandfather was a former toolmaker, and he lived to be 99, just 3 months shy of 100. In his lifetime, he saw the invention of the airplane, the car, and a culture that moved from outhouses to bathrooms and boasted a TV and a phone in every home. Unfortunately, he attributed his longevity to daily chaws of Red Man tobacco. I remember my brother and I talking about his life when he died, and I was 9. I never thought my life would see changes like that. But I would suggest that you and we are part of the digital revolution and the information age and computers and the transformation of electronic health records, electronic laboratory reporting, registries like cancer and immunizations, and now surveillance for public health diseases and conditions that we never thought that we could do effectively and do it well. And transformational things like electronic case reporting. And so finally, I'm going to close with this, and I think you all probably picked these up when you came in the room, and I just want to highlight this. This is the Data Elemental to Health initiative. It's an initiative sponsored by CSTE, and it's about a coordinated, comprehensive strategic approach to building a public health data superhighway. There are 2 big parts. It's system investment and it's people investment. So we need data scientists to help us transform our data systems to evolve to meet future challenges. And it's the data and the workforce that are the lifeblood of public health. So our ask is this, which is for this year, CDC needs $100 million as a down payment in fiscal year 2020 to begin to modernize and harmonize public health data systems at the agency and at state and local health departments. So in closing, I just want to say that our nation's response to health threats is only as good as the quality of the input data and how efficiently and effectively it is moved into and through the public health data system. We are on the threshold of an amazing time to accelerate disease prevention. And this initiative, led by CSTE, the Association of Public Health Laboratories, HIMSS, or the Healthcare Information Management Systems Society, and NAPSIS, the National Association of Public Health Statistics or Vital Records, is about getting the right data to public health at the right time to make the right decisions. Things get better when people make things better. And to paraphrase Margaret Mead, can one person make changes in the world? In fact, it is the only way anything ever gets changed. Everyone is responsible to improve the quality of life in your community, the quality of health. Now more than ever, people need public health surveillance and data presented clearly, the existential importance of epidemiology and public health surveillance.
Hello, everyone. My name is Tony Galbo. My daughter, Gabriella Jada Galbo, she was born in 2006, and she passed away in 2012. On May 1st in 2012, I'll try to speed this up. It's a long story, so on the 1st, she got a fever, about 104.5. My wife brought her in. She was diagnosed with strep. She did a swab. They grew it out in a culture, and it was negative. The next day, my wife went back to the doctor. We went to the ER about 11 o'clock on May 2nd at night, and Gabby had about 104.5 fever. She started breaking out in a rash around her neck, hands, and feet. We took her out to the ER. They kept her there for 4 hours. They gave her 2 shots of Rocephin, and they said, "We think this is tonsillitis." I've never seen a rash with tonsillitis. So my wife, 8 hours after being discharged, called the pediatrician again on that day 3, May 3rd, and about noon, and she said, "I want Gabby to be seen today." So my wife took her about 18 miles back to the pediatrician. This is day 2 of the pediatrician now. And she said, "Oh, it's not tonsillitis. Discontinue the antibiotics that they gave, and we think it's Coxsackie virus, atypical." So my wife went home and was very diligent about looking up Coxsackie virus, knowing the course, how high the fever should run, and then from there, we thought we had a handle on it. On day 4, we kept her home, kept giving her ibuprofen, Tylenol, control the fever at bay. Day 5, Gabby was so lethargic, her gait was off, her urine output was gone. Trying to get her to drink some water was a task. Trying to get her to eat was a task. We had been now to the doctor 4 out of 5 days. We were frustrated, but we thought of Coxsackie virus, so okay. I went to work. My daughter had a first communion that day, my middle daughter. We went to that. I went to work. I got a call about 9 p.m. that day, and Gabby at this time was just laying in a cot, not doing much. My wife said, "Her fever's at 106.1. What do we do?" And I completely lost it. My wife said, "Why are you mad at me? I'm not mad at you. I'm mad at the system. We've been to the ER twice. We've been to the pediatrician twice. What do we do?" So I immediately called patient advisory. They told me immediately call 911, but then we'd be brought to the critical access hospital that we already went to. So we took her via our car. We got her to the ER about 20 miles away. We got in there. I started grabbing doctors. What is going on here? 106.1 fever. They said, "Oh, she's fine. You know, she hasn't urinated in 23 hours. She's fine." I said, "How do we get her hydrated?" I said, "How about some IV?" He goes, "You can give her a spoonful of water every 15 minutes. I'm like, am I in the twilight zone? So we immediately pushed for the IV. From there, he pushed the CBC and the CMP. 4.5 hours went by. Nobody was coming in and checking. That original doctor left office shift. Another doctor came back in, and this was about 3:34 in the morning, and he came in, and he was very nonchalant, never touched my daughter, and he said, "Gabby's good to go." And I said, "Did you guys look at the blood work?" Because now Gabby's covered in a rash, head to toe. Like I said, she's got so many signs of sepsis, but we didn't know sepsis at that time. And he said, "Just have her urinate, and we can go." I'm like, "Gabby, do you have to go?" Finally, the 2 boluses that we gave her, she had to go. I picked her up, brought her to the bathroom. I guarded that urine like it was gold. I wish I would have flushed it down the toilet, because then they wouldn't have had a urine sample, and we would have maybe been admitted. But we submitted that urine sample. They looked at it. They said it was just fine. It was very dark amber. It had proteins, and it had a lot of problems with it, showing signs of kidney, liver dysfunction in her CMP. The doctor, we asked 3 times, is her blood work okay? 3 times he said it's fine. He got more agitated each time we asked. He finally left and said, you guys are good to go. We went home, and I was left looking outside going, what do we do? My sister was with us, my wife and I, and she said, something's not right. And I said, what do you want me to do? We've been now 6 out of 7 days. I don't know what to do anymore. So we went home. The next day, Gabby's fever was about 99 or 100. And I was doing yard work because we were going on a Disney cruise on that Friday, on May 10th. We were taking off from Bloomington, Atlanta to Orlando. And then the next day on May 11th, we were going to, on May 12th, we were getting ready to go on a cruise. So the next day, my wife, I was doing yard work. Her fever had gotten to 99, 100, and I was like, what is this? Her fever's gone. She's getting better. But now we look back, it was her immune system waving a white flag. She was in serious, serious trouble. When we were discharged, she was in septic shock. We look back now and see that. The doctors missed multiple signs of septic shock. They missed multiple signs of SEERS. When he discharged her, she had 18 out of 25 abnormal markers on her labs between a CBC and a CMP. Her platelets were at 80,000. Her bandemia, which you should have none present on your labs, but when they are present, no more than 6%. She had 23% present in her body, so she had a major infection roaring in her. So my wife the next day called the doctor on May 7th, the pediatrician now, and she said, we want Gabby to be seen. She's just so lethargic. Something's not right. Pediatrician called me back and said, if you guys want to bring her in today, if not tomorrow. And I said, did you guys look at the blood work? And I hear in the background, hold on a second. And I hear in the background, it's a mess. Get her in here now. So immediately, what do? I demanded, what is my assurance I was going to get admitted this time? And she said, we're putting records in. We immediately put her back in the truck, skipped the critical access hospital, got her to Champaign, and started grabbing doctors this time. Now I was beyond agitated. I said, forget about yesterday. Fix my daughter. And every time a doctor came in, they left. It was like everybody was hiding from the situation. There was a child life specialist, and I know a few of you know what they are, but they come in, they comfort the family, they comfort the child to make sure everything's okay. And they, want any blankets, books. And I said, we need a doctor. That's what we need. And the reason I bring her up, she was the only one in that hospital that listened to me. She left, and I said, good riddance. She came back 5 minutes later with a pediatrician from the 7th floor in tow. She listened. She got it. We got transferred upstairs. Again, everybody was just complacent. No sepsis talk, nothing. She was admitted upstairs on pediatric floor at 7. The first time she got her broad-spectrum antibiotic was at midnight. That was 5 hours. The first time she should have got sepsis protocol would have been 50 hours prior, from Saturday, May 5th at 10 p.m. to the beginning of May 8th at midnight. That's 50 hours went by. And every hour you delay treatment, 8% mortality goes up. So again, we were waiting. Nothing was being done. Gabby started swelling around her eyes, hands, and feet, and I called the doctor in after she just left, and I said, what is going on? And they said, we have to, keep an eye on that. That's called third spacing. I didn't know what that was, but third spacing is very serious. And then her blood pressure plummeted, and then that's when I said, I want her transferred to Peoria. And that was a children's hospital about 90 miles away. And they said, no, she's fine. She's just got a virus. So again, I trusted these guys. And they said, as soon as I see that Gabby needs transferred, I will transfer her. The next day, we went through lumbar puncture. We went through multiple tests. I wouldn't leave her side. At 9 p.m. on May 8th, Gabby, the doctor had just left her office. Her room. My wife was in a room with them. It was dark. It was very cold in that room. And I was between the room, literally 5 feet between that and the hallway, talking to my mom and dad. And I saw the doctor and nurse leave, and I immediately grabbed him, and I said, what's going on? Oh, nothing, we're just checking on her. I went in the room. Gabby's now stomach is distended beyond belief. She's panting 87 breaths a minute. She was in distress, and I do not know what their plan of action was, but I don't know how many more signs my little girl was showing them to say, help me. So I immediately said, what is going on? They said, we have to transfer her. Or I said, I want her transferred now. And they said, we can't. She's not critical. When I asked 24 hours earlier, that's when we should have got her transferred. That's when they should have properly intubated her. When they intubated her, they gave her a Glasgow score of 5. Gabby was not at a 5. Normal's 15. She was maybe a 14 because she was a little dehydrated, confused. The last word she said to me was, "Dad, don't go. I want my mom." So I reluctantly left. My wife made me leave because they were going to call security. I did not trust them anymore at that point. An hour and a half went by after intubation, and I kept asking, what is going on? We got my daughter back out. Her neck was swollen. Her face was protruding, just swollen. Tongue was protruding out. And I said, what happened? This is normal. And it was not normal. Life flight guys came. They picked her up. It was very hard now to trust a whole new set of guys with your daughter. And they had to get her to Peoria immediately, but they had to make sure she was okay. You could tell they were very disgusted and angry with my daughter's condition. And they explained that to me when they got to Peoria. But when she got to Peoria, it was like the President of the United States landed. They had hematologists, cardiologists, infectious disease. They had ECMO for pediatric. They had oscillating ventilator. That's where she should have been brought first. When you hit a criteria, you need to be transferred to the correct hospital. You do not keep at a smaller hospital, and Carle Hospital is not a small hospital. It's a 750-bed unit, but they're not equipped to take care of critical care children. So that's when they need to get it. So we got the first sign of transparency there on May 9th. Tony and Liz, your daughter has a high chance of dying. She probably will not survive. That was the first time I heard those words. And I thought, this doctor's nuts. My daughter's a fighter. And they put her in ECMO, and that is horrific on its own. Then they had to do, her stomach just couldn't take the swelling anymore, so they had to do compartments surgery. They opened up her stomach and left it open. And right away, Gabby got better, and we're thinking, okay, we were so naive then. She had so much damage to the brain, from the Rocky Mountain spotted fever to the sepsis, to the HLH, to the neglect. On May 10th, we got the first news that your daughter's brain function is gone. They did one last test, which was on an EEG on May 11th, the morning. And I prayed to God. I prayed to anybody that would listen. I sang to her. She was so swollen. The doctors did not recognize her. They thought my daughter was 100 pounds normal. My wife was carrying a picture around her neck. And the doctor said, "Is that Gabby?" And I said, "Yes." He said, "We got to get her back to that state." But I think he was trying to appease us. She went into the hospital at 47 pounds. And after she died, she was over 100 pounds. So when she died, I was keeping her hands, her ears, her face, her feet warm, because I was losing that battle with body heat. And that's when I promised her she'd be Gabby's Law. We knew of the mistakes. We didn't know all of them. So my wife and I had fought from day one. We immediately took charge. We grieved as we did this. The pediatrician thought of Rocky Mountain spotted fever on day 3. And the CDC's recommendation is, if you think of it positively or negatively, in testing regardless, you treat with doxycycline, because it's going to show back negative for 2 to 3 weeks. By the time it's positive, the patient has already passed away. The pediatrician also saw my daughter's labs from May 5th and 6th, the morning of day 7, which was May 7th. And at 7:30 and 9 a.m., she came in her office. She saw Gabby had been in the ER, saw Gabby's horrific labs at 7:30, and then at 9 a.m. said, "Oh my God, she's been discharged." But not once did she advocate for my daughter. Not once did she call the nurse and say, "Get them on the phone, put everybody on hold until we get this family in here. This child is in serious condition." When my wife called in at noon and she called me back at 3:47 p.m., She acted like that was the first time she saw my daughter's blood work. But it was actually her third time. And we heard this during deposition, and that is not do no harm. That is not do no harm. You advocate for the patient. 3 doctors in total thought of tick-borne disease on days 3, 7, and 8, and not one of them treated my daughter with doxycycline. A total of 8 doctors, 6 nurses, in the matter of day 1 through day 8, the first hospital saw my daughter, and they failed my daughter. The first time she got actual treatment, love, care, touch, was at Peoria Children's Hospital. So I owe them my heart. You know, today is 2,523 days that Gabby has been gone. You know, so I really do appreciate Christian inviting me on this. And, you know, we'll talk about legislation when you guys are ready. But, you know, I do appreciate it.
Good afternoon, everyone. I'm Tammy Brown. I am the Associate Director of State Government Affairs and Policy for Merck, and my point disease state for the whole State Government Affairs Department is C. diff. So it's an honor for me to be here, and it's an honor to see all of you that work so hard to prevent this disease and prevent our loved ones from dying from such a horrible disease. Merck State Government Affairs put a lot of time and money into doing some research on CDI, and what we found is that there are a number of states that still aren't reporting, and that there's a wide range of data that's out there. And we heard that from our representative from the CDC, and I thank you so much for your work. A couple of states that I wanted to report on are states that are doing things beyond what is mandated federally. We've got 29 states that require reporting of CDI. We've got 8 states that have state-mandated CDI reporting, and those states are Maine, Connecticut, New Jersey, Pennsylvania, Delaware, Massachusetts, Oklahoma, and Oregon. And then we have 4 states that require reporting without state law, and they are Minnesota, Nebraska, Ohio, and Wyoming. We want to grow those states. We want to make this something that is that has state mandates across the country. As you heard, you know, the funding comes from the federal government, but it's got to start on a state level. So we're working on that. We've got a whole slew of policy considerations that we're taking a look at. Mostly that all states should collect lab-reported rates of CDI in a consistent manner, because right now the reporting is all over the place, and make the information publicly available. One of the things that we're doing, and it's an honor to work with Christian and PLF, is that we're working with PLF on model legislation, and we'll use our relationships at the state level in the legislature to move that model legislation through. One other thing is that it's important that we educate our legislators. As it stands right now, there are too few legislators that even know what CDI is. So first, starting to work with those legislators that represent areas where you all come from, that represent your counties, your towns, and let them know what CDI is and tell them your stories. Secondly, we need to spread out to the health committees in every state and tell the stories of what's happened with your families. So with that, I'm willing to answer any questions that you may have, but I just wanted to kind of keep this short so that we can move on with our program. Thank you.
Are these on? Can you hear me? Great. So I thought we'd just take a couple of minutes, because Tony didn't have a chance really yet to explain what he's done since those awful, difficult days. And I thought, Tony, maybe I could just start with a quick question to talk a little bit about how you took those moments and turned it into advocacy on a state level. And then, we should open it up to discussions. You have a lot of experts here, so we should take questions after that. But what were the first couple of steps that you took to get started on getting Gabby's Law passed?
Well, the first thing that I want to say is reiterate, we have to educate the legislator. That I want to say that right now before I lose train of thought on that. That is so important, because as Trevor would know, in Indiana, we educated Representative Mahan. And from there, in the beginning, he was reluctant. And then all of a sudden, when he realized, holy cow, sepsis is this big and this bad, that is the first step. So you have to get their attention. But the first thing we did was I called my U.S. congressman, and I thought everybody was going to listen to me. And he immediately told me, you have to do this in the state. Before you do this federally, let's do this in the state and see what your state does, and try to have 2 or 3 states involved in this. So immediately I called everybody, from State Medical Board to the Attorney General of Illinois. So then I found my state legislation and my representative and my state senator. I called them, and one thing about them is I thought they were going to blow me off like everybody had been to this point. They listened, they cared, and they immediately took my phone call, met with me the next day, they met with me again. And from there, it was a few meetings. It was very tiring. You felt like, what I want to say is this, is some people are going to ignore you, not because they're ignoring you, because they're busy. They're going to get back to you. Some people are going to ignore you because they want you to go away, all right? So the biggest thing is you got to be persistent. You got to keep picking up that phone, be congenial, but you hit a point where how much more can I take of this? It's time to listen. So that was one of the key things of balancing, hey, my daughter died, wake up. So the good thing about them is our state senator had a common sense and a heart. He saw the issue at hand. He figured out how we could do this. Gabby's Law not only pertains to sepsis, but one thing we're working with is the Patient's Bill of Rights standard of care, because my daughter was dropped on every level through those 11 days, Actually, the first 8 days, because I can't blame the Children's Hospital. They did everything they could. But that was very important, is to get the right guy, and once you get it, get their attention, and don't go away.
Right, so it can be as simple as starting with your own story and your own interaction, right? And just meeting with your local legislator and saying, I have a story to tell you. This should never happen again.
Bring pictures.
Let's work together, bring pictures. Did you also meet with other organizations or other people? Did you bring?
At that point, no. We were left. It was 2013. We were by ourselves, and we were dealing with so many different things. And I just kept meeting with them. And that's a good thing about our state senator. His aides, his staff, they were caring. And I think yesterday we touched base, or maybe it was today, behind a good legislator is a great staff. And you're going to really figure that one out, is those guys are meet and greet, but you got to get the attention of the staff. You got to really brainwash those aides and say, this is why sepsis is important. This is why Rocky Mountain spotted fever, tick-borne disease is important. This is why the standard of care is important. C. diff. You got to get their attention. You got to get them on board, because that's who you're going to be working with. Then from there, they're going to sit there and pursue to persuade the senator or congressman from there. So,
Right, thank you. So I think maybe we'll take a moment now and see if people have questions. Anybody have questions? Okay, maybe we'll just keep going here. So we have, oh, do we have a question here? Oh, sorry. So you have a story. You bring it to your legislator. It's also important, as we heard, right, to consider when you come up with the solution. And the lucky thing is we have the Peggy Lillis Foundation, so we can work together and we can be sharing information in the different states and with all of our experts that we have relationships with on the federal level and on the state level to identify perhaps a model bill, a model piece of legislation that you want to pass. And by having that model bill, you can talk to people about the kinds of things that are important to them in their own state, right? So what is important to those specific legislators? What kind of resources do they have in the state? What is the hospital system like? Luckily for many of the states, we do have CDI rates, right? So you can go in armed with that information to be able to press that this is an issue. These are the numbers of people in my state and in your community, legislator so-and-so, that this is affecting, and we need to work together. Then there's also a role, of course, in the media. Does anybody want to speak from our panel on the role of the media in spreading the word and educating people? Did you work with the media at all, Tony?
yeah, the media, they had to walk a fine line in our town because their biggest advertiser was the hospital that failed my daughter.
Right.
So
there's a challenge.
they would tell my story, but they would say it was a lot less severe than we made it sound. Mm-hmm. And if you get online, you'll see it. The Galbos are still dealing with it. Well, what are the Galbos dealing with? Their daughter just died of a just normal thing that happened. That's what it says here in the paper. But if they heard the story, if you get on gabbyslaw.org and see what my daughter or my wife wrote about my daughter and that story, you'll read about it. And we left a lot of things out there because there's so many horrific details. Not that we're trying to protect anybody. It's just like, how much more can we write about this? But the media really tiptoed around the situation, and that has always been frustrating with me. We had a lot of meetings with stakeholders, so I don't want to jump ahead.
Yeah,
so
no, that's great. Yeah, so we can talk about that as well, right? So what of course, you'll be more successful and more powerful if you can think about the other people who have the same kinds of desires and issues that you're trying to push forward, right? So who in the room is your law going to affect? What are the stakeholders, right? So, for example, it might be you want to talk to the hospital association or the medical society or the nurses or infectious disease professionals. There are many different organizations that you want to at least introduce your idea to and see how you can work with them and or identify who might be your opposition, right,
yeah.
through that.
And in the beginning, everybody's your opposition because they will not admit that sepsis is a problem, and they will not admit that C. diff is a problem. They're going to completely deny that because they don't want, first of all, and I'm going to be honest, I've seen it, they don't want the extra work. They don't want the extra paperwork. They don't want to go through the red tape. But in the beginning, no, we don't have a problem. Well, how do we get to 300,000 people a year? If you divide that by 50 states, and I know I'm doing it the layman term because every state's pop, but it's 5,000 a state. And some states are registering that they only had 1,500 deaths or 2,500 deaths. If you do the math, it still doesn't add up, So you're telling me California, New York, and Illinois are having 20, 30,000 deaths of sepsis? No. So the reporting is not there. So that's where it gets real sketchy. You have to get thick skin. You have to take their criticism, and you got to tell them, no, there is a problem here. My daughter died. My daughter's not an isolated story, not only with sepsis, but with the standard of care, with hospital mistakes. This is going on far too frequent and every day. So that was one thing, is we had to get the IHA on board, the Department of Public Health. They're probably the hardest ones to get on board, to tell you the truth. But the IHA was on board immediately from the get-go. And we saw the same thing go on in Indiana. We don't have a problem. And then, boom, they were forced by the legislator to say, hey, this is good policy. We're not going to quit this. So that was a challenge, but it can be overcome.
Right. Questions? Yes, Lori.
Just a comment. So we worked on a law in New Hampshire for healthcare-associated reporting, healthcare-associated infection reporting, and I remember my sister and I went after we lost my mom. She had started out her healthcare journey with a MRSA sepsis after surgery, and then recovered, but then died of a medical error. But when we went into the room the first time, we were so excited because the room was packed with people, and we thought everyone is here to testify for healthcare-associated infection reporting. And we quickly realized we were the only two people there to do that. Everybody else was, either a healthcare lobbyist or from the hospitals. But one thing I think that really changed for us, two things. I am a nurse, and I was a grieving daughter, and I was just so angry that this had happened. My sister took a more sort of academic approach, and she has worked in the healthcare industry. So I spoke about the human suffering and the medical errors and the infections. My sister talked about it in terms of what it cost financially. And at that point, you could have heard a pin drop in the room. It totally changed the culture in the room that moment when they heard how much it cost for hospitalization. The other thing is that we wrote a letter to the editor, and it was put in as an op-ed, so it was a pretty big article. And at the end, we asked people to reach out to us who had suffered a healthcare-associated infection, and our phone was ringing off the hook. So we then, the next time we went, brought all those people with us, and that was very powerful as well. So just a couple of things that worked for us.
I'll say that I've seen legislation actually pass just based on the stories from patients' family, the testimony that's been given in that committee. So, many of the committee members came in, not thinking anything, but the stories that are told are moving. So I appreciate your comment.
Right.
Go ahead.
I was just going to add to that. I think when I was with AARP, and we were also working to pass the state health care associated infection reporting law, we were going to various legislators, right? So like the one who represents you is most likely to accept your request for a meeting, but you want to start with whatever committee is going to be hearing the bill that you're working towards. So usually it's the health committee. So we were making our rounds, and as sad as it is, almost everyone that we met with, almost every legislator, had somebody either in their family or close to them who had suffered from an infection. And probably the same was true with Tony and sepsis, right? So when people find a way to relate, whether it's they know somebody that has suffered as well, or as Lori mentioned, you come up with the argument from another angle, finances, if finances works. So if you come at the issue from a few different ways, whether it's children or population health or the state of the budget in your state, and we can't afford to keep having our hospital resources drained for infections or other healthcare errors, those might be the arguments that resonate. So to kind of cast a wide net and to include the legislators and see what connects with each legislator that drives them to have the passion for the issue.
And that's a great question, because I have it written down here. That was the next thing we're going to talk about is on the third or fourth meeting, I was getting their attention, but my daughter's death wasn't enough. 300,000 people. Back then, I think it was 228,000 people had died of sepsis a year. The number just keeps rising. But on the fourth visit, I said, this is costing $26 billion a year. And that's the pin drop. That's when you get their attention, And it was, I told them my daughter's bill was $450,000. The first 2 days was about $50,000 at that other hospital. But when she got finally to Children's Hospital, that was roughly about $400,000. So that's, and I got to come home with my daughter, deceased, pick out a casket, plan a funeral, And that's what $450,000 showed for me. You know, and the other thing about once everybody starts realizing what C. diff is, just like sepsis was, in the state capitol when they went to vote on it, Senator Rose got up there, he got on the floor, he spoke about Gabby's just briefly, and all of a sudden he waited for a debate, and Senator Delgado got up, and I was like, please don't go negative, because that's what I was feeling. I'm a pessimist, you know? So he got up and he said, I'm ashamed of myself. I should have done this 8 years earlier. My constituent's daughter died. And then all of a sudden, another person, Senator Maddie Hunter, got up and she said, my father died 3 years ago. I should have done something for this. And it was the 7 degrees of separation. You'll hear me say that a lot. But when it's sepsis degrees of separation, it's only 1 or 2. And C. diff, you're going to start seeing the same thing. As people start realizing what it is, what they're learning, as it's being reported correctly, you're not going to be in the 4 or 3. It's going to be in the 2 or 1 again. And that's what the goal is. But they unanimously passed it. They're on the Senate floor, and all of a sudden a lot of people wanted co-sponsorship on it. So let's, I know we're out of time on that.
Great, thanks. Unless there's one last question? All right, thank you so much. And just remember, you're all advocates. If you've ever taken a stand for a grade that you didn't think was the right grade, or you stood up for your neighbor or your friend and fought against some level of injustice, that's what advocacy is. So you have it all in you. And tomorrow you're going to get a chance to do it, which I think is what we're moving into next, talking about Lobby Day. No, not yet? One more thing. Okay. Keep it in the back of your head. Thank you.